You are all welcome to the webinar this day, the 21st of August 2025. This is an AORTIC Central African webinar. My name is Ngala Calvin. I am the current Vice President of AORTIC, that is the African Organization for Research in Cancer of Central Africa. We welcome you all to this webinar of today. I will be co-hosting the program with Manjo Florence, who is the Secretary General-elect for AORTIC. So today we have a presenter, Dr. Fedja Gislen, a radiologist and a graduate of the Faculty of Medicine and Biomedical Sciences, University of Yaoundé 1 in Cameroon. He has over 7 years of experience working with the Cameroon Baptist Convention Health Services. His main research areas or interests or main areas of interest are pediatric and adult oncology, imaging, digital health, and teleradiology. He is a member of the Cameroon Pediatric Oncology Group and AORTIC, and actively participate in oncology multidisciplinary teams. In addition, he serves as a faculty member at the Baptist Institute of Health Sciences in Bingo in Cameroon, where he contributes to the training of internists and surgeons. Dr. Fedja currently works at the tertiary referral hospital, that's Bingo Baptist Hospital, which has a very busy oncology unit where approximately 80% of imaging workups, particularly CT scans, are dedicated to cancer diagnosis and staging. Without any waste of time, I will hand over to him. He will be doing a webinar this day titled Current Perspective in Cancer Diagnosis Using Imaging in Sub-Saharan Africa. Over to you, Dr. Fedja.
Thank you, Calvin, for giving me the floor. I'm eligible enough. Let me just share my slides. Okay, thank you enough. I'd like to thank AORTIC for giving me the opportunity to present on the webinar series. So today I will present you on the current perspective in cancer diagnosis using imaging in Sub-Saharan Africa. So this is the outline we are going to follow. It seems long, but it will not be so long. So as introduction, the cancer incidence and mortality are rapidly increasing across Sub-Saharan Africa. There is a notable epidemiologic transition from infectious disease to non-communicable disease like cancer. So gone are the day where every patient will have HIV, or internists were only seeing patient with HIV. Now we are more in the area of cancer. If you are internist or health worker, you don't know about cancer, it's challenging now in our time. It's not like in the past, people used to have many HIV patients. So in front of cancer diagnosis, many healthcare systems face significant challenges. And for the cancer diagnosis, medical imaging is one of the tools that we use. It's a cornerstone of modern oncology, providing a non-invasive window into the human body that is critical in every stage of cancer journey. So from the very first suspicion of disease to long-term surveillance after treatment, imaging technology at the eyes of clinical team enable accurate diagnosis, precise treatment planning, and effective monitoring. So you cannot talk about cancer patients without having to talk about medical imaging in the whole journey of the patient. So why is it essential? At the early detection, at the accurate staging, essential in the for early detection, accurate staging, treatment planning, and monitoring. So imaging supports intervention such as radiotherapy and minimally invasive procedure. But what we notice is that imaging services are predominantly located in urban centers, so not quite frequent in rural area. And diagnosis is often delayed due to infrastructure gaps and low awareness. So that in case of sensitization, many patients don't know about their cancer, or they delay before they come to the hospital. So that when it comes to diagnosis, imaging, just see what the patient comes with. So what is the importance of imaging? In the case of early detection and screening, we use tools such as X-ray and mammography to find cancer before symptoms even appear. Like in the case of breast cancer, mammography can detect the lesion before the patient even starts feeling the symptoms. Imaging also provides a safe and accessible way for the initial evaluation of suspicion lumps with ultrasound. We can distinguish between simple SIP from solid masses that need further investigation. So once a mass is identified, biopsy done, pathology result given, now we pass on staging. And staging is done with CT scan. We give a detailed anatomic map of the body to see the tumor size and determine if you are spared to nearby lymph node or distant organs. So you have talked about X-ray, mammography, ultrasound. There's also MRI, but not quite available in our context, in our setting. It provides a detailed characterization, offering a high-resolution view that is crucial for planning surgery, mostly in the brain. You cannot do a brain surgery for cancer without having MRI to really have a look at it, a thorough look. And the last imaging modality that we use, PET-CT, which is not quite available in our Sub-Saharan Africa context. It reveals the tumor metabolic activity, showing how aggressive the cancer cells are. So this functional modality is vital to identify hidden metastases that you can miss on CT scan and MRI. So at times when it's quite challenging, we go to PET-CT to rule out any metastasis that was not seen on the CT scan and MRI. To show the importance of imaging in the oncology, the American College of Radiology has worked with other societies on many classifications. You have the BRADs, the TRADs, the LRADs, the ORADs. There are so many. So BRADs is for the breast, TRADs for thyroid, PRADs for prostate, LRADs for the liver, and ORADs for the ovary. So what is their role? It helps to classify finding and assess the likelihood of malignancy. So it's a common language used by radiologists to describe and classify finding, improving communication and consistency. When we take, for example, the BRADs, is the breast. It's classified from 0 to 6. With it, you can really know when you give the likelihood. If you say BRAD 5, you know that one is really suspicious of cancer. So in that case, you will know whether you go ahead to do biopsy or not. Because not all the patients having maybe breast mass, thyroid mass, and malignant. So when we give you the likelihood of malignancy is for you to go ahead and do now invasive procedure. Want to do your biopsy, your family aspirate. With it, you can now go ahead. The LRADs, same thing for the LRADs for the liver, in case of hepatocellular carcinoma or liver cancer. So another aspect of imaging, apart from the early screening, is the surveillance. when you have treated your patient, you give maybe, if the patient is supposed to receive 6 cycles of chemotherapy, you give the 3 first cycle, you want to control. There's what we call the RECIST criteria, response evaluation criteria in solid tumor. So it's a standard way to measure how well the cancer patient responds to treatment. It's based on whether the tumor shrink, stay the same, or get bigger. So what is, he has a whole criteria, but what, in summary, when a patient do a first scan before starting the treatment, chemotherapy or the therapy, you do the scan. Now at the interval, at the half, at the middle, you do and you compare with the first one. So that when you give a report, sometimes you have to give the size. So that when you do the control, you compare the size to give the response to the clinician, the oncologist, whether there's complete response, partial response, progressive disease, or stable disease. So it depends on your primary site that you are measuring. So you may challenge it if you change the hospital and go to do another one, you need to compare from the report. It's always good to compare from the images, because somebody can be measuring the biggest, the maximum, the size from AP, anterior, posterior, clinical. So these are always things that at times can be challenging when you do your control style scan in a different hospital. So for this one is for surveillance, for the oncologist to know whether his treatment has worked or not, or what they have to do to change the treatment or to readjust. So in summary, you have the screening and early detection, initial evaluation, anatomical mapping and staging with CT scan MRI, distal soft tissue assessment with MRI, metabolic and functional assessment with PET and CT. So those are the key aspects, the areas where imaging is important in the cancer journey. From the beginning, from the screening, the diagnosis, the follow-up, the surveillance, until the complete treatment. We can control and see that there's nothing. Even patients with breast cancer that need to be controlling mammography after 1 year, after 5 years, imaging will still be there to follow up. So we are already named the modality. And from the modality, there are some characteristics that we are checking, so that we can be able to tell you that this is suspicious, this is not suspicious. So for ultrasound, we have what they call solids versus 6C feature, whether the mass is vascularized, meaning that there's really blood flow inside the mass, whether the margins are regular, irregular. So that's for ultrasound. For mammography, we check for microcalcification. In X-ray, we check for bone lesion, metastasis. CT scan, you have the tumor density, the enhancement pattern. Like in the case of hepatocellular carcinoma, we tell you that is hyper-enhanced in the arterial phase and use them like washout. Whether there's local invasion, metastasis. MRI and PET-CT give a more thorough analysis of the lesion. So this is an example of these are ovarian cysts. So if you're able to see my console, that is using the ORAS classification, the ovary radiological diagnostic system. You can see here that we have thick septation above 3 millimeter is suspicious. Here we have nodularity is suspicious. Solid component suspicious. So this is suspicious for malignancy. On this side, instead, you have a simple ovarian cyst. The enhancement is peripheral. So here is benign, but here they are really suspicious. Here is peripheral, we have solid component inside of papillary projection. So there's a whole table giving details how we can trace this one is suspicious or not, depending on the solid component and the vascularization. So this is X-ray of the bones. There's always a controversy in case of bone for osteomyelitis, osteosarcoma. It's always challenging because at times maybe treating a patient for osteomyelitis, why is osteosarcoma? Even though we say tissue is the issue, but X-ray will first guide you for the livelihood, because the patient may be sitting there, they just think that it's osteomyelitis, they start giving antibiotic. When you look at these three images, so they are characteristic, the way the cortex, the cortex line is completely destruction of the cortex. This one was confirmed as osteosarcoma, while this one is instead osteomyelitis, and this one is granuloma osteophyllidis. So these first two, these are the common one where there's always trouble. Is it osteomyelitis? Is it osteosarcoma? There are many criteria: the age, the location, whether it's diaphysis, whether it's epiphysis, whether it's metaphysis. All those criteria are taken into consideration before you can conclude. On this one is the same thing. First one, you see that is what they call the Kahneman triangle. There's like periosteal elevation. This one is still osteomyelitis infection. So with the X-ray, you can really see how to go ahead, because if there's a solid mass here, you need to do biopsy. This one, you need to try with favor. When there's doubt, you can do biopsy for both. But the thing that is not good is just to treat for osteomyelitis and osteosarcoma. There's always good, if there's a doubt, to send another colleague who is more versed with this kind of X-ray. So this is a typical image that you have. These are osteosclerotic metastasis in our country is already due to prostate cancer. So these are images of X-ray, how X-ray can help you in a cancer diagnosis. So this one is also sclerotic metastasis. They say this case was a case of breast cancer. You see how the lesion looks subtle, but you really need to have a good X-ray machine also to really appreciate. So this one you may think that maybe it's Paget disease, but it's prostate metastasis. So when we come to CT scan, we have our own way in CT scan to determine the likelihood of malignancy. So this is the case of a liver mass in a 43-year-old female. When we talk of, this is the liver mass at the arterial phase, the venous phase, and the leg phase. So that's why we usually say the protocol for HCC, when they say, people say triple phase. These are the triple phase, but normally it's quadruple phase. I've not put the non-contrast phase here. So we see some enhancement. This is what you call arterial enhancement of the mass. On the venous phase, you are normal see it. On the delay phase, you are normal see it. So for us in radiology, is suspicion of a hepatocellular carcinoma. Even though now we also talk now of intrahepatic cholangiocarcinoma, that can be a differential. But we need associated symptom like maybe if you have portal vein thrombosis, you may really think that this is really something like hepatocellular carcinoma. So typically, this is how we sort of wash out on the hepatocellular carcinoma. Look at the face. So you need a good, you need a machine, CT machine with an injector to be able to trace. Because if you miss the first one, you'll not be able to really talk about the other phases. The delay phase, you see the excretion here on the kidney. So let me just say what about breast cancer imaging, because this is the most common female cancer in developing countries. And by the way, when a patient comes to the hospital with a breast mass, what do you think should be able, the patient has to consult? So there's a question that is quite challenging. You have a relative that has a breast lump, you want to consult in a hospital. What do you think the patient can go to? Which specialist? Is it internist, gynecologist, surgeon? If people can write, if people can write in the chat so that we can see at the end, because there's always something that is confusing. we're supposed to consult the patient with the breast mass? Is it a gynecologist? Is it a surgeon? Is it an oncologist? Is it a radiologist? So it's quite tricky. But what the patient wants at the end is proper care. Whether who consult the patient, the clinician should do the work well. Because we are noticed instances where the surgeon consult, he removed the breast mass and was not sent for pathology. Or a gynecologist consult and does not deem necessary to do biopsy. Or the patient has done ultrasound, they talk about fibroadenoma or your breast cancer. So despite the fact that the patient come late, you also have our own role to play in the management of those patients. So imaging play a crucial role for breast cancer screening, for classifying and sampling non-palpable breast abnormality, as well as defending the extent of breast tumor locally, regionally, and at distant sites. So how do we do for breast cancer in the imaging? There's what we call early detection. Mammography identified micro calcification and small lesion. But it does not mean that you must do mammography on all the patients. There are some criteria. We have so many recommendations. The US Preventive Service Task Force recommend mammography for women between 40 to 74. You have the ACR criteria, we talk about 50. But in our Sub-Saharan African context, we can even go around 35 because the breast incidence in young female is quite high. The issue with mammography is the breast density. In young people, the breast density is so high that it can obscure a lesion. So that's why we don't advise mammography in young people, because you're not able to differentiate from that breast density in mass that is hiding. So no, I see you are not supposed to do that. Check about the age and breast density. So as from 35, 40 years, you can appreciate better a breast lesion. So what do we do for them? You have to do ultrasound. So it will be difficult to do screen mammography in a young female of 25 years because the breast density cannot allow you to differentiate anything. So that's why it's not advisable at that age. Even if you have the risk factor, or you just have to do ultrasound. It's true that the other modality, maybe MRI, but I'm talking about the modality that are available in our context, because it will not be quite interesting to send a patient for MRI of the breast while they are not started what is available. The patient has to travel for some distance to be able to do it. So screening is for those who don't have asymptomatic, they don't have a lesion. They don't want to check that one 40, 45, 50 years, and you control after 2 years. Diagnostic mammography for those who have a breast lesion and the age is above 40. When you have a breast lesion, you have to go back for ultrasound to be able to appreciate. So we should not work because people think that mammography diagnose breast cancer more than ultrasound. It's an issue of age, density, and all the other factors. Echography will not see macro classification that mammography will see. So that is the issue between mammography and ultrasound. At 45 years, you can do both, to be sure. But they are not the one to tell you that it's breast cancer. They are the one to tell you the likelihood of malignancy before you go now for biopsy. So they are there to make some of triage to tell you that this is amendable for biopsy, this is amendable for FNA. And you have to use the Barra classification at the end. It's true, when it comes to ultrasound, clinicians always complain that radiologists, technician, imaging technician always only diagnose fibroadenoma. So it depends now. I used to say operator dependent. Yes, focal adenoma is the most common one, who is benign. So you have to use the Barrett classification. You cannot do a breast ultrasound without using the Barrett class at the end. You have to see whether it's 2, 3, 4, 5. And from there, if it's 4, 5, you need to do biopsy. At 3, is surveillance. You can control after 3 months, or depend on you. If the patient is at risk, you can go out for biopsy. So even if they tell you that it's focal adenoma, please, you can go ahead and do your FNA or biopsy if the patient has other risk factor. Because by the way, when we start, a radiologist start to do breast ultrasound or mammography, he also do his own physical exam. He also asks questions to be sure about the circumstances. If it's family history, that one you need to be thorough. So there's a whole protocol on about breast ultrasound mammography. And ultrasound can also help to guide for biopsy if the lesion is small, because for large lesion, you don't need the ultrasound, you just go ahead. And I will say tissue is the issue. We will not just do mammography, ultrasound, and say breast cancer, and the patient will just go, no. They still need to do biopsy to confirm their suspicion. So this is our criteria of the BRAS classification. So we look at the breast composition, the shape of the mass, the margin, the orientation. So there are so many criteria that people doing the breast ultrasound, whether radiologists, whether image technician, sonographer, they need to check them and report whether the mass is over. You have to report all these criteria before the end you conclude. So let me just show some example of some breast ultrasound report taken from radiology assistant. So you wonder, how do you still have people giving result focal adenoma while at the end it called breast cancer? It depends on the training and many other factors. So you have the breast cyst here. This is typical focal adenoma. It's hypoechoic, homogeneous, what we call posterior enhancement. This is a cancer. You see the outline, the first irregular from this one, you already know that it is suspicious. So this is just a glandular tissue, like a breast, normal breast anatomy that is just prominent. So this is where we have to really expatiate when you are doing a report, the margin, the orientation, the shadowing, all those characteristics. Those doing breast ultrasound should know them and should report them. And on this one, we have all these are breast and malignant breast lesion ultrasound speculated. So with this one, we put Barrett for BRAS 4, 5, other 4A, 4B, 4C, and you have to go for biopsy. So when they are small like this, you need to do ultrasound to be able to direct you. When it comes to mammography, is it's not like operator dependent, it's not experience dependent, because it's so nice to do it, but to interpret it is quite challenging sometimes. So you need some experience to be able to interpret. So this is speculated lesion. This was likely of malignancy. So normally when you do like that, you have to go now maybe ultrasound to appreciate like this image. Ultrasound is there. So at times it's always good that the same radiologist do both, because the result of one can help you to interpret the other. So it's always good to do in combination to have a good diagnosis for the next step. So this is this is a case of breast cancer on CT scan. See, this is the breast mass. These are already metastasis in the liver, metastasis in the bone, as you can see here. So this one is stage 4. So this is why you commonly have a lot of patients for CT scan for breast cancer staging. You know that distal spread, we do CT tap, thoracoabdominal pelvic, we can do PET scan. So the other cancer I also want to take for a few minutes is hepatocellular carcinoma. It's diagnosed at very late stage in Sub-Saharan Africa due to lack of routine surveillance and limited access to advanced diagnostic imaging. Imaging is really key in the issue of hepatocellular carcinoma because we can diagnose it without using biopsy. But in some instances, as I say, the differential it can be intrahepatic cholangiocarcinoma. But when you have feature like portal vein thrombosis is likely to be, or tumor thrombus is likely to be hepatocellular carcinoma. Like for example, this case, this is a lady we got this week of 21-year-old, hepatitis B positive. She has a large liver mass. You see the outline from here, we consider as liver cirrhotic. And she was not diagnosed, I cannot say like, she was symptomatic, epigastric pain. She had never done ultrasound. So she came in our facility to just ultrasound, and we just discovered the breast mass. She was the liver mass, and she was sent for CT scan. So the patient has, from here, he has portal vein thrombosis affecting the main portal vein and the branches. The patient already have liver long mets. So it's quite a challenging case, 21 years. So we cannot really trace what happened. Did she not do surveillance? Did she not know that she has a liver lesion? So all those things is something that when you do thorough consultation before you can understand what happened. But normally with imaging, you can follow up HCC to avoid such circumstances. So the protocol say nodule below 1 centimeter, you do ultrasound, you repeat after 4 months. If it's stable, you allow. If it change, you go to CT scan. If CT scan give you the hallmark, that is high arterial hyperenhancement with portal washout is HCC. Some few cases, it can be, you can think about intrahepatic cholangiocarcinoma, as I say. Now you also have the, yes, after now you can depend, you can have CT scan, you can have MRI that can help you to really be sure. When you are not sure, go to biopsy. So even interventional radiology help for hepatocellular carcinoma. You can have radiofrequency ablation, transarterial chemoembolization. These are done by interventional radiologists. That are not so common in our Sub-Saharan context, African context. They starting, some hospital in some countries are started having the facility to do it. So let us talk about the challenges that we have in our context, the diagnostic challenges. The first category is infrastructure. In the Sub-Saharan Africa, we have outdated or limited imaging equipment used to have power outages, poor maintenance. Because when you have ultrasound machine, maybe that was used in the West, they come in our context there. The probe is disturbing, so you have so many issues. You have electricity that is not stable. The human resources, we have few radiologists, radiographers, limited training. We don't have enough subspecialty. Because in the West, you have people specialized in neuro, oncologic imaging, abdominal imaging, that can give you some clue. And you can need to meet diagnosis. Because the way you report even, maybe you're not reporting what the clinician wants, because you are not really used to that field. So it's good to discuss with your clinician. You have economic barrier, high imaging cost, because the machine are also expensive. CT scan and MRI are quite expensive. Ultrasound and X-ray are quite cheap. And patients pay out from their pocket. That's the challenge. There's no medical insurance in many of our countries. Geographic inequality, imaging centers are mostly in big cities. So patients have to travel for long distance, rural patients. And at times, some patients are not even quite referred well to go to those big centers. Even they are referred, they cannot go with transport issue and financial issue. In the policy, cancer is not prioritized in many of our countries. We have weak regulation, we have poor data and statistics. Patient factor, late symptom reporting, late stage diagnosis, low awareness, and no comprehensive screening program. So according to the modality, what is challenging? X-ray is available, ultrasound is available, mammography is limited availability, is mostly in urban area, in private center. Screening program are rare, some program Like in Cameroon, you have the women health program. They have been doing some screening to help to diagnose cancer early or breast lesion early. Computer tomography is now quite available, but it's still in big city and expensive. So have issue of maintenance. Most of them, when you have some maintenance downtime time, it can make 1 month, 2 months because the parts are quite expensive. MRI is limited availability, not really available. Few machines per country. Even when they're available, they're in a big hospital, referral hospital, and the cost is high. PET scan is rare, even though some South African countries, South Africa, Kenya, Nigeria, interventional radiology is also rare, but gradually we are seeing in some hospitals. So what can we do for the way to improve? In the domain of infrastructure, we need to do some other source of electricity, solar, backup system, hydroelectric dam. Normally, imaging is difficult to run without, if you have some issue with electricity, it's difficult for imaging because our machines are quite sensitive. You need something like a generator, so one light down, you back up. That why in many imaging facilities, the machine can really get breakdown because of interrupted electricity. Infrastructure, establish regional diagnostic hub. For example, in Cameroon, you have in each region, the government has tried to put some regional diagnostic hub center having CT scan and MRI. So those are things that are quite good for the system, for the imaging accessibility. The workforce, you need to expand training program for radiologists, radiographer, strengthen partnership with university and international training body. We also use the area of teleradiology, and you have to use AI tool. The AI tool that helps you to diagnose, to help you for ultrasound, breast ultrasound. You take the image, you send it to the AI tool, it will tell you whether it's likely benign or likely malignant. So this is that you need to incorporate to be able to save they don't have access. So the initially take the image, is sent to the AI tool, it can give the response. In the area, we don't have many radiologists to be able to do all those breast ultrasound, ultrasound. Economy and financing, that one concerns the government, but we can develop public-private partnership for equipment acquisition and maintenance. Because you get the machine, but when there's a breakdown, you don't know what to do. Because the biomedical was supposed to take care are not available, or the company, maybe the company is right in China, you need to send somebody, you need to do remote checkup. It's always good to establish, to do maintenance contract with this imaging machine, as they are quite expensive. Concerning the policy, we need some integrate cancer imaging into national cancer control program and into universal health coverage. So what can be the current perspective? As we don't have enough equipment, enough radiologists, we need now mostly teamwork and collaboration. Because in cancer journey, accurate diagnosis require multidisciplinary input. So go to the area where you diagnose, you send the patient, one clinician to the patient and just allow it. You cannot treat a patient with cancer alone. So you need to do tumor board, the oncologist, the pathologist, everybody involved in the team. Because the radiologist will give a report, you are not sure about it, you just discard and decide to repeat. I think the good way is to ask the person to give an idea of what was written, maybe the terms, you are not understood the terms. So because I saw a patient have 3 CT scan because they're suspecting retroperitoneal mass. At the end, it was not there. Because there's some area imaging that we know that radiology are quite challenging. Diagnosis of retroperitoneal mass, there are some things that can be challenging. So it's good to discuss with the person or the team. We are the area in WhatsApp, can easily get the contact and discuss with the person. So you are no more, this century, you cannot more work in isolation when it comes to cancer care or care in general for a patient. So you can do capacity building at this webinar to see how to discuss about some issue concerning the specific cancer. Remote collaboration. You have WhatsApp, you have Telegram. You can easily send an email to one colleague that is expert in his field. I can give you a diagnosis. WhatsApp based tumor board or virtual consult. It's really important to have a collaboration about the actors in the field, being pathologists, oncologists, radiologists. Referral network. As I talk about regional imaging hub, yes. Even regional, even the specialists, if you are in your field, you are more also doing brain, abdomen, can create a hub and discuss with the colleagues their challenging cases. Can partner with community health program, integrate screening into outreach effort. We also need imaging protocol for cancer staging. Because some may report in their own way, at the end, you find yourself 3 different reports, 3 different ways of giving the report. At the end, the oncologists can be confused. So when we come together, we can now have imaging protocol, and I also say we cannot do without artificial intelligence in some aspect. So, in conclusion, despite the challenges of limited equipment, workforce shortage, and infrastructure inequality, imaging remains an indispensable pillar in the fight against cancer in Sub-Saharan Africa. In resource-constrained setting, even basic imaging modality like X-ray and ultrasound X-ray can improve outcome when used strategically and collaboratively. As I've shown the image of osteosarcoma, you see it's already a clue. You don't need to go right to CT scan. They are not it. Collaboratively, if you are in doubt, you send to somebody specialized, because there are people specialized maybe in musculoskeletal that can tell this one is osteosarcoma at 80%. It's not osteomyelitis, so that you don't be cheating something while at the end the patient is a different issue. So the ultrasound, we show the breast ultrasound, how you can diagnose the BRAS at BRAS classification 5, that this is cancer, just go for biopsy. So encouragingly, computer tomography is becoming widely available, offering enhanced diagnostic precision for staging and monitoring complex cases. Now, CT scan, we do thoracoabdominopelvic. It is quite expensive in some area, but at least it's gradually available, and the oncologists use it widely to be able to do their staging so that they can tailor their treatment. So imaging is more than a diagnostic tool. It's a gateway to timely, equitable, and life-saving cancer care. Because there are some situations where we call oncology emergency, when you're suspecting cord compression, maybe from spine metastasis. In that case, when you do the CT scan, you can appreciate whether there's vertebral compression, fracture, for urgent referral in a radiotherapy center. So imaging is all the step of the cancer journey. So it should not be looked at as imaging that modality that is not quite useful for the cancer journey. Because even in the case of brain metastasis, you need to do an urgent brain CT to be able to appreciate. It's not kind of cancer needs to stay. So urgent cancer, appropriate referral so that you can save the patient. So as we are preparing for the AORTIC in Tunisia from the 2nd to the 5th November, when the team is advancing cancer care across Africa, you should also understand that imaging also helps in the advancing of the cancer care across Africa, despite the limited equipment and workforce. Because we cannot be thinking, even though PET scan is really important in the cancer journey, but what we have, we can first work with it. Before some patients that can afford for referral in whether in the West, whether in India, they can do it. But for what you have now, I think oncologists, they are doing their best, what is available, to treat the patient successfully. These are the references I used for my presentation. Thank you very much for your kind attention.
Thank you very much, for this very brilliant presentation. I'll be handing over to Andrew Florence.
Well, we really want to appreciate Dr. Fejo for this great presentation. I think I've learned a lot with what you have done this afternoon. I'm so grateful. Unfortunately, some of our colleagues are just joining in now. So if you just join in now, Dr. Fejo, maybe one of the things we want to know, will you be sharing your slide with us so that people can go through? Because some people just join as you were on your conclusion.
Okay, yes, possible.
Thank you so much. That would really be great. That would really be helpful. And I want to call on each and everyone who is here who took time to listen to Dr. Fejo. We've come to know that imaging is not just a diagnostic tool, but it is for timely intervention, equitable intervention. So please, do we have questions for Dr. Fejo? Do we have contributions? If so, please just raise your hand and we are going to give you the chance. If you cannot talk, please, you can equally write on the chat and I think Dr. Fejo will be very pleased to answer you. Yes, Dr. Tumsi, I can see your hand. Please, over to you.
Good afternoon, and thank you very much for this opportunity. I also want to thank Dr. Fejo for his very enlightening presentation this afternoon. I just have a contribution to make in terms of another aspect of how imaging can help us in the cancer journey of a patient, and that's in radiotherapy. So modern radiotherapy techniques includes what we call image-guided radiotherapy, where we use modalities like the CT scan or the MRI, for patient positioning and verification of the patient's position so that you ensure that you're treating the exact same area each time, as well as sparing the precious organs or the organs at risk. So that's an important aspect of imaging in that cancer journey. So you have aspects like the dedicated CT simulator. In high-income countries, they have now evolved to using MRI-guided treatments. But you also have things like simple ultrasound for brachytherapy treatments. Thank you very much.
Well, thank you so much, Dr. Tumsi. I'm grateful to know that these are some of the things that are happening, and even in the low and middle income countries. Thank you so much. Please, I will just beg that you lower your hand so that we can see others who have questions or contributions. Please feel free to write on the chat or feel free to raise your hand and we give you the chance. And just like I said, many people came late, and the good thing is that Dr. Fejo will be sharing his slides. So this AORTIC Secretariat will be getting back to the rest of us who have registered for this webinar so that we can get these slides and go through. And if you have questions, you can still channel these questions through the AORTIC Secretariat, and Dr. Fejo will get to you and read through the questions. So looking at everything, I see that there are no questions, and I'm not seeing a hand, maybe no question. Okay, thank you so much, Dr. Mopeta. Please, the floor is yours.
Thank you very much. Good afternoon. Wonderful presentation. Mine is a comment. I saw there was tissue is the issue, and I happen to be a pathologist. But one thing I'd like to just say is with regard to, especially with regard to bone lesions, they can be a headache to the pathologist without radiology. And that's a time when we really need the expertise of radiology to come through. Even things as simple as a chronic distinguishing, in some cases, chronic osteomyelitis from osteosarcoma without radiology and pathology can be a headache. That's one. Number two, even when we have the cancers in multiple sites, in my practice, I like, as you shared, the multidisciplinary approach, because sometimes we see a metastatic cancer, and given the low resource to do immunohistochemistry, sometimes a walk or a chat with a fellow radiologist goes a long way in cutting down the cost for the patients. And that has been my little experience in this space. Otherwise, thank you so much for this interaction.
Well, thank you so much. I'm grateful for this contribution and your comments, because when we look at everything, we really encourage multidisciplinary approach of care. Truly, it reduces the cost for the patient, and the time that the patient spends in the hospital is equally reduced. So we really encourage multidisciplinary approach. Thank you so much. I'm grateful for your comment and your contributions. Do we have another person who wants to contribute or who wants to ask a question? So if you have a question, like I earlier mentioned, later on, please address this to the AORTIC Secretariat, and we are going to answer you. Over to you, the moderator. Thank you.
Thank you, Madam Florence. Thanks to all of you for your attendance, taking time off from your busy schedules for this webinar. I want to really appreciate you, and equally to mention that the recording for this webinar will be available by this period. Thank you very much, and we call it a close to this webinar of today. Thank you, and have a blessed day.